It's my honor to be the one who wraps up the Earl Davie Symposium today, and thank you all for sticking around. In the next 20 minutes, I'll be discussing vaccine-induced immune thrombotic thrombocytopenia, VITT, and I'll be referring to this entity as VITT. And I'll also be discussing briefly about the experience of British Columbia in the evaluation and management of VITT. I don't have any relevant disclosures. And I think a good start of the discussion is defining VITT and talking a little bit about the epidemiology of this new entity. So VITT is a rare prothrombotic disorder that can happen after exposure to one of the adenoviral vector vaccines like AstraZeneca or Johnson & Johnson. And it has been referred to as TTS, thrombosis and thrombocytopenia syndrome in some of the literature, as well as VIPIT, vaccine-induced prothrombotic immune thrombocytopenia, but the consensus now is to stick with VITT. There are no definite VITT cases after exposure to mRNA vaccine. There was a suspected case of VITT in the United States after Moderna, but that was not confirmed, and the final conclusion was that that was a case of spontaneous hit. So everything started in April when there were several case reports and case series published in the literature from different regions in the world, starting from Norway, in which 5 patients were reported after exposure to AstraZeneca vaccine, and then in Germany there was 11 patients, and in the States there was a report of 12 patients after exposure to Johnson & Johnson vaccine. So the incidence is variable from region to region in the world. I have to highlight that in Norway the incidence was the highest, which was 1 in 26,000 individuals, and in the States it was about 1 in 500,000 individuals, and this is really a very low incidence, to be honest. People were asking about risk of having VITT after second dose of AstraZeneca, and the data came from UK, in which they reported 15 cases of VITT after 9 million second doses of AstraZeneca, and that is an incidence of about 1 in 600,000 doses. The case fatality was initially high when the disease started in April. That's because the management was not very well established, but nowadays the case fatality dropped significantly to 20% or even less than 20% in some of the literature. In Canada, the first case of VITT was reported in Quebec in April 2021 this year. And again, the incidence is variable from province to province. In Ontario, for example, the incidence is about 1 in 61,000. In BC, the incidence is about 1 in 92,000. And here in BC, we investigated 68 individuals with suspected VITT, out of which 3 were confirmed to be cases of true VITT. Of these 3 patients, no mortality was observed. So I want to spend some time discussing the pathophysiology of VITT, albeit not very well understood, but I think a good way to discuss the pathophysiology of VITT is to remind ourselves about the pathophysiology of HIT, which there are similarities between these two entities. Now, heparin-induced thrombocytopenia happens after exposure to heparin. It's most of the time heparin-dependent. And what happens is that heparin binds to platelet factor 4, which results in neoantigen exposure on PF4 that will stimulate B cells to produce anti-PF4 heparin antibodies, and the immune complex then can activate platelets, and some of the patients will go on to develop thrombosis. Now, there are several types of HIT. Classic HIT is the one that is heparin dependent, but there are cases in which HIT can happen independent of any exposure to heparin, and these are called spontaneous HIT. And what happens here is that the patient will have some other polyanions. So heparin is characteristically known to be a polyanion. So these patients will have other types of polyanions circulating in the plasma that will bind to PF4 and results in conformational change that will stimulate the formation of antibodies. And characteristically, spontaneous HIT is seen after orthopedic surgery, particularly knee replacement surgery. In some of the medical patients, spontaneous HIT can be seen after bacterial or viral infection. Now, the pathophysiology of VITT is very similar to that of spontaneous HIT in a sense that it's not heparin dependent. So I want to highlight this study that was published in Nature. And this study looked at the binding sites of VITT antibody and compared that with the binding sites of HIT antibody. And what the study found essentially is that the binding sites of HIT antibodies on PF4 are different from those of VITT antibodies. In fact, HIT antibody typically has a specific binding site on PF4, unlike VITT antibody, which can be polyspecific. Now, that point is very important because it explains one of the significant problems that we see in the lab when we try to investigate cases of VITT. And initially when VITT started, people didn't know what's going on, but now we know what's the problem. So this is related to the first line screening assay that we use to investigate cases of HIT. And that is an assay which is developed by Instrumentation Laboratory Hemosil. And it's a competitive assay. So in cases of HIT, so basically the assay utilizes latex particles that are coated with monoclonal antibodies that are similar to HIT antibodies. And so when you get a plasma from a patient with HIT and mix it with this reagent, the HIT antibody will compete with the monoclonal antibody that is coating this latex particle and will cause displacement of the monoclonal antibody, and that will result in decreased agglutination that will then be detected spectrophotometrically by the change in light absorbance. Because VITT antibodies have different binding sites from HIT antibodies, if you use this assay to screen for VITT, you will get false negative results because the VITT antibody will not compete with that monoclonal antibody that is coating the latex particle. And this is very important because the recommendations came to avoid using this assay to screen for cases of VITT. Another study that I want to highlight is this one, which was published by Greinacher and his colleagues. And this study looked at the mechanisms of which VITT causes thrombosis and stimulates antibody formation. This study tried to understand what in the vaccine is specifically the part that stimulates the antibody formation. And what they found is that most likely the outer coat of the adenoviral vector, which is also known as hexone, is the part that is implicated in cases of VITT. So that binds with PF4 and stimulates the antibody formation. The other mechanism that happens is the formation of or release of neutrophil extracellular traps, which are procoagulant components, as you know. So this image shows the complex of PF4 on the surface of platelets with the adenoviral vector, and the next image on the right shows the complex which is also bound to the immunoglobulin. A little bit about the clinical manifestations of VITT. Obviously, thrombosis is the main symptom that patients have, and usually thrombosis in these patients will be in an unusual sites like the splanchnic veins or cerebral veins, and some patients will even have arterial thromboses. Thrombocytopenia, of course, is another symptom, and usually these patients will present within 4 to 28 days after exposure to one of the adenoviral vector vaccines. The diagnosis is confirmed by PF4 ELISA assay, and the PF4 ELISA assay is usually positive if the optical density is more than 0.4, but in cases of VITT, the optical density tends to be between 2 to 3. The ELISA itself can be diagnostic in the right clinical context, but in some cases you can have false positive ELISA, and therefore in some of the cases you will have to confirm the diagnosis by using a functional assay like the serotonin release assay. And I just want to show this study which was conducted in Norway. They looked at individuals who were vaccinated with AstraZeneca, and they performed PF4 ELISA on these individuals, and they found that in 492 individuals who are asymptomatic with no thrombocytopenia, normal platelet count, 6 individuals had a positive PF4 ELISA, which was false positive. These individuals were healthy. They didn't have any clinical issues. I want to show you one of the 3 patients with VITT that were diagnosed here in BC, and this is the clinical course of this patient. So day 0 when the patient got the vaccine, and then around day 12 the patient started to have symptoms, and this patient actually had a difficult clinical course. The patient had portal vein thrombosis and required a surgical resection because of bowel ischemia. But immediately when the patient started having symptoms, the patient was given IVIG doses, and you can see the black squares represent the platelet count, the line of the platelet count, and the black triangle is the line for the D-dimer. So initially when the patient presented, the patient had a platelet count of about around 50, and after given IVI, and the D-dimer at that time was about above 35 milligram per liter, which is very high. So once the patient received IVIG, the platelet count improved and D-dimer dropped, and at that time when PF4 ELISA results came back, it showed optical density of 2.6, which is again very high. So the patient continued to be on anticoagulation therapy, of course, non-heparin anticoagulation, and D-dimer gradually dropped to more recently undetectable or less than 5. And the platelet count initially went up to close to 300, but then there was a drop in the platelet count again. So we repeated PF4 ELISA, and it was still positive at 1.3. The patient got another dose of IVIG, and there was a slight improvement in the platelet count, but then the platelet count plateaued. So this is about now more than 6 months since the patient first presented, and we repeated PF4 ELISA after 6 months, which continued to be positive, but at a lower level of optical density. So in BC, when the first reports of VITT were published in the literature, even before that, a clinical care pathway was developed, and the idea was to aid in the evaluation and management of cases of VITT, particularly in areas, in rural and low resource areas. And through this clinical care pathway, 68 patients, as I said, were investigated, out of which 3 were positive cases. So I don't want to go through the whole clinical care pathway. It's actually available online, but I just want to highlight a few things. The patient presents at local hospital. The standard in blood investigations will be performed locally, and samples for PF4 ELISA and SRA will be sent to St. Paul's Hospital or Vancouver Island. These are the two sites that perform the PF4 ELISA. And if there was a high index of suspicion for VITT, the PF4 ELISA will be performed within 24 to 48 hours. If not, then the sample will be batched for twice weekly testing. And the clinical care pathway really shows how to deal with these patients from the time of presentation. So this is what I just said about the lab investigations of these patients and how to deal with samples from patients with suspected VITT. The last thing I want to show is these graphs from the 68 individuals who were evaluated for suspected VITT. And so we divided these 68 patients into three groups. The first group is the three confirmed positive VITT cases. The other group is non-VITT, but patients who presented with thrombosis for other reasons. And the third group is non-VITT and without thrombosis. And you just can see that the platelet count is significantly different between the three groups, and more importantly, that platelet count in cases of VITT was significantly lower than the two groups. And also the same thing can be observed with D-dimer and PF4 ELISA. I just want to highlight that the shaded area represent the normal reference ranges. So the take-home messages from this presentation is VITT is a very rare prothrombotic event, which is seen only after exposure to adenoviral vector vaccines. The incidence ranges from 1 in 50,000 to 1 in 100,000. And it's linked, as I said, to adenoviral vector vaccines. Prompt diagnosis and management is necessary to have a better outcome. Antibody formations triggered by polyanionic vaccine particles, and the clinical care pathway standardizes evaluation and management and reduces mortality, and the diagnosis is confirmed by PF4 ELISA and SRA in some cases, and obviously avoid using rapid enzyme immunoassay or lattice particle immunoturbidometric assay for screening for cases of VITT. And I want to thank my supervisors, Dr. Tyler Smith and Dr. Agnes Lee. Thank you.
Questions? I have one for you. What's the benefit of doing the serotonin release assay? What's that telling you?
Yeah, so the serotonin release assay is a platelet activation assay, which looks at, PF4 ELISA is just going to show you that if there is antibody circulating in the plasma or not, but serotonin release assay is a functional assay that will gives you an idea if there is real platelet activation. And as I said, there are some cases with false positive ELISA. So this follows the model of the iceberg. There are patients with circulating antibodies, but they don't have any symptoms. So in these cases where you have false positive ELISA, you will need to confirm by serotonin release assay to make sure that these patients do not actually have platelet activation.
Is there some reason that you couldn't do that by looking at CD62 expression on the platelet by flow cytometry? Is there like another alternative methodology than sending samples to McMaster?
It's possible, and it has been done and published in the literature. I think that will be, we don't have the or actually I shouldn't say we don't have it. We have it, but it's going to be more sophisticated actually to do the flow cytometry assay on these patients than sending for SRA. Yeah.
That was a great talk. Thanks very much.
Thank you.
I'm at Prydesdale. It's the frequency is about 1 in 75,000 in Canada. To put things into perspective, what is it for HIT?
Oh, it's a good question. I'm not sure of the incidence of HIT,
A lot higher.
Yeah,
A lot, and that's an
definitely.
acceptable rate.
Yeah.
So just to put things into perspective, my real question is, I haven't read this literature in a little while, namely a few months. Have any risk factors for VITT been identified as yet?
So not really. The last paper that was published actually last week by in JTH looked at a different summarized the whole literature that is available since VITT was just went was initially published. But I don't think. Or maybe I'm not aware of any risk factors that can be pointed out. Yeah.
Thank you.
Hi, Ed Conway. That was really interesting. The serotonin release assay, so my understanding is that you distinguish it really from HIT because it's positive in the absence of heparin. Is that not true?
Sorry, say that again.
It's positive. You get a release response with
Yes.
VIT in the absence. You don't
Yes.
require heparin to be added.
That's true.
Okay, so that's one. So, and then the word on the street is that you don't want to treat these patients with heparin. So can you explain why not? And in fact, in your patient you treated, or Aggie's patient is treated with fondaparinux, which is short version or the most active portion of heparin. So why is that? Because I understood that heparin could actually potentially compete with the immune complex formation. So why would heparin be bad necessarily? If we've got the mechanism right.
Yeah, so again, this is it's really new entity, and there's a lot of things that we don't know about, and there are a lot of theories, and I think because heparin is a polyanion, it will probably further stimulate the antibody formation by binding to PF4. That's only my guess. I'm not. Yeah.
Have any patients with HIT been diagnosed with VITT?
Not that I'm aware of.
Yeah, so
Thank you.
Apropos Ed's question, I spoke to Walkingtons and various other people, and people ran away from heparin initially. I think people agreed on GG, but I think that some people are receiving heparin. The concern obviously was the overlap with the clinical syndrome that scared people off.
Right.
Yeah.
Thank you, Dr. Carter.
Okay, thank you very much.
Thank you.